Hi, everyone. Good evening. This is Catherine Mickelson, the Executive Director of the North American Thrombosis Forum. Thank you so much for joining us this evening for our online support group. Before we get started, I just wanted to remind everyone that all the participant lines are muted to help cut down on background noise. So if you have any questions for Dr. Piazza, I encourage you to submit them using the chat function, which is in your toolbar for GoToWebinar. We are also monitoring the info at natfonline.org email if you prefer to email your question in. And we'll try to address as many questions as possible. So now I'm totally honored to introduce Dr. Gregory Piazza, who's a cardiologist at Brigham and Women's Hospital and an assistant professor at Harvard Medical School. He's also on the board of directors of NATF and serves as our education chair. So he is a perfect choice to answer all your questions. So if you are ready, Dr. Piazza, we got tons of questions in, and we will go ahead and get started.
Well, definitely ready. So let's have at it.
So I'm sure, as you can imagine, a lot of the questions that we got in for this evening are around COVID-19 and blood clots. So just generally speaking, can you kind of talk to our patients who have had a PE or DVT at a higher risk of, first of all, contracting COVID-19 or having a poor outcome from COVID-19?
Yeah, so it's a great question. It's come up continuously throughout this pandemic. Having had a DVT or PE in and of itself does not flag a patient as increased risk for either catching COVID-19 or having an adverse clinical outcome. But some of the conditions that may predispose to developing VTE, such as if you had VTE due to recurrent hospitalizations for heart failure or chronic kidney disease or chronic respiratory illness, those could put you at increased risk for a poor outcome related to COVID-19, not necessarily the DVT or PE. The only caveat to that would be if you had a number of different pulmonary emboli and had developed pulmonary hypertension, then you would be in a higher risk category.
Okay, so that's good to know. So patients with DVT or PE, while they should still practice all the CDC recommended guidelines around social distancing and hand washing, probably aren't at a higher risk of contracting or having a poor outcome from COVID-19. So that's great news. So this patient was told last month that they can come off of their blood thinners, but they're wondering if there's any benefit to staying on them now because of COVID-19.
Another great question. There have been some reports that a lot of the morbidity and mortality associated with COVID-19 is related to activation of the clotting system, and that anticoagulation may help to mitigate that risk. We don't know if patients that are just on anticoagulation for other reasons enjoy a lower risk of complications due to COVID-19. This is something that's actively being studied. We're looking at it in our group, and a number of other groups are taking a look at that. But right now, that wouldn't be a real evidence-based indication to keep you on anticoagulation.
Okay. So this is kind of a more general question, but what is a simple way to reduce the risk of a blood clot with people working from home now?
Well, I think that it's important to make sure you're remaining as mobile as you can. Getting out, it's a recommendation just for your overall health to get out of your seat at least once an hour and walk around, get the circulation moving, get up and hydrate, take a bio break, so to speak. Those are all important things. One of the unfortunate things about working from home is the readily available quantities of food. So making sure that you're maintaining a healthy diet and not taking in more calories than you need just because you're bored at home. or busy working. That's also important. And not forgetting exercise. If you're not walking to work or walking around, climbing stairs at work, and you're really just sitting at home, you'll be pretty immobile. You won't get your steps in for the day. So you want to set aside extra time. You don't have a commute, right? The commute's gone. So you can use that time to work out, and really should take advantage of this time to double down on your heart health and exercise and eat healthy.
Excellent. And do you have any recommendations for patients who need regular PT, INR blood draws or medical lab visits? And what are your thoughts on home testing?
Oh, I just had this conversation with a patient today who was inquiring about home testing. Home testing is a great idea for the majority of patients on warfarin. And I mean, it's hard to make an argument against home testing. Home testing's associated with better patient satisfaction. A lot of patients have better control of their INRs with home testing. I'm all for it. And this is just another reason why home testing is a great idea, because you don't have to go to the lab and expose yourself to others who may have COVID-19. That said, the last thing we want patients doing is skipping INR draws, impacting the adjustment of their warfarin because of fear of contracting COVID-19, because COVID-19 is a big deal, but also intracranial hemorrhage due to mismanaged warfarin, or a blood clot because your levels are dropping low, is just a big deal, if not worse. And so clearly you want to work out something with your anticoagulation management clinic where you can make sure that you can safely get your INRs checked as often as they need to be checked. That said, a lot of patients have been asking about switching to direct oral anticoagulants, and we've done that as well, and that's another good option.
Mm-hmm. And are these all questions that can generally be handled using telemedicine, or do these require an in-person visit?
No, that's a perfect telemedicine question.
Awesome. And is it relatively easy in your experience? I know a lot of this is insurance dependent, but to get patients set up with home INR monitors?
It's easy.
Okay.
Yeah.
Awesome. So I know a lot of patients are followed at anticoagulation clinics, and at least the one at Brigham and Women's has a lot of great resources for patients who are interested in going that route.
Yeah, and if you're interested in home testing, you can always contact the clinician that manages you through these anticoagulation management services, and they actually will take care of all of the process of getting you the machine.
Awesome. Okay, great. Well, I believe those are not the majority, the questions that we had come in about COVID-19 and blood clots. So why don't we go ahead and move on to some of the other questions that came in. The first one is, does hydration, so drinking an adequate amount of water, have a measurable impact on clotting disorders?
Clotting disorders is a broad term, so I'm going to try to answer it a little bit more narrowly so we can actually get an answer. Hydration is very important for preventing venous thromboembolism. We've realized over the last 5 years or so that a lot of these idiopathic or unprovoked episodes of venous thromboembolism were probably predisposed by dehydration. We actually think that probably the people who develop venous thromboembolism from long haul air travel probably have less of an effect of the air travel and probably more an effect of being dehydrated. So hydration is always a good thing, from kidney stones to preventing VTE. It's smart to stay hydrated.
Definitely. Okay. Can you speak to best practices for hip replacement surgery for patients with a history of pulmonary embolism?
Very common question. The most important thing is to make sure that patients who are undergoing hip replacement receive some thromboprophylactic measures. Now, in someone who's had a pulmonary embolism before, that's all the more reason to make sure there's a system in place to make sure that patients are getting evidence-based thromboprophylaxis or preventive anticoagulation. And there's so many options, ranging anywhere from aspirin to the direct oral anticoagulants. There's currently a large study that Dr. Goldhaber is involved with called PEPPER that's looking at the impact of aspirin for prevention of venous thromboembolism in those undergoing total hip and total knee. But also very well studied in this population is warfarin, injectables, and direct oral anticoagulants. So orthopedic surgeons have more at their disposal now than ever before, and the most important thing is just that they pick something that they're comfortable with and apply it to patients.
Okay. How many years after experience of pulmonary embolism can a patient expect to feel residual mild pain or discomfort in the chest? This woman in particular is a 68-year-old female. She had a PE in 2015. She was on Xarelto, and after 2.5 years was then put on Savesa. Now she's taking NSAIDs to relieve, or can she take NSAIDs to relieve the pain?
Yeah, so the most important thing would be to figure out why she may be having chest pain. There are many reasons for having chest pain after pulmonary embolism. Not all of them are actually related to pulmonary embolism or the post-pulmonary embolism syndrome. Sometimes patients develop high pressures in the pulmonary arteries after pulmonary embolism, and that can cause chest pain. That has a specific treatment. Other times there could be a musculoskeletal reason, a gastrointestinal reason, a neurological reason, or other cardiac reason. And so a workup for that chest pain is important. We usually start with an echocardiogram to see how the patient's healing or has healed from the pulmonary embolism. Regarding the question of whether there's a certain time frame, it's very common for patients to feel some chest discomfort with pulmonary embolism in the first several months after pulmonary embolism. I would say like 90% or higher will feel that chest discomfort goes away probably within the first year. For those that have symptoms past that, an inquiry into why those symptoms are there and whether they're related to something else becomes really important. Regarding non-steroidal anti-inflammatories and being on anticoagulation and whether you can take them or not, that's something that varies from provider to provider. I'm more permissive about that. I usually allow my patients to use low to moderate doses of non-steroidal anti-inflammatories on an as-needed basis, or if they have to use it several days in a row for up to a week at a time. It's not so much that the non-steroidal anti-inflammatory is going to increase the effect of your anticoagulant necessarily, but what it can do is predispose to peptic ulcer disease, which then will bleed more profusely on an anticoagulant. So it's wise to prescribe caution when using those, but I have many patients who the only thing that works for them when they do get their headaches or backaches or whatever is a little bit of non-steroidal anti-inflammatory, and I don't withhold that from them. It just doesn't seem fair to do so.
Okay. All right, so definitely worth following up with her clinician.
Yeah.
All right, can you talk about bleeding on the new DOACs and the risk associated with a major bleed in comparison to warfarin?
Sure. So all of the direct oral anticoagulants have a greater safety profile than warfarin, depending on the specific direct oral anticoagulant. There may be more or less of a reduction in major bleeding, but all of them essentially reduce major bleeding, reduce clinically relevant non-major bleeding, reduce fatal bleeding, and reduce intracranial hemorrhage. So it's all very, very promising and a great benefit to patients. Some of them, there are 5 different direct oral anticoagulants, and some of them are associated with more bleeding in one place than another. All of them are better than warfarin overall from a safety standpoint. And now with the reversal agents, even if there is a bleed, there's a very specific way of addressing the bleeding with these drugs, which further enhances their safety.
That's great. Okay, can you tell us a little bit about the Caravaggio study
Sure.
and how that might impact patients with cancer-associated thrombosis?
Sure. So Caravaggio was a wonderful study that was just presented at the American College of Cardiology, which wasn't held in person because of the COVID-19 pandemic. But the most important of the trials that were submitted to that conference for presentation actually were presented virtually. And Caravaggio was one of those. Caravaggio was a study that looked at patients who had venous thromboembolism, either deep vein thrombosis or pulmonary embolism in the setting of cancer. And they looked at whether apixaban, which is one of the direct oral anticoagulants that many of you will know as Eliquis, could be used to protect patients from recurrent blood clots when they've already suffered one of these DVTs or pulmonary embolisms. The standard of care for a long time has been an injectable blood thinner, but injections are a hardship that is difficult for anyone, let alone a cancer patient that already has so many other discomforts. And so they studied apixaban versus a injectable anticoagulant, and lo and behold, apixaban actually performed quite well, protecting patients very, very nicely from recurrent blood clots, but also doing it safely. And I think of all of the cancer trials, this was one of the first ones to really substantially show that apixaban and probably many of the other direct oral anticoagulants, when those ones get studied in similar trials, have a potential to replace the injections, which are an incredible burden. So Caravaggio was very important. It was the most positive of all of these studies, at least published to date. And I think guidelines are probably going to change because of Caravaggio, because it was a pretty conclusive trial, and it adds something very important to our toolkit for treating cancer-related thrombosis.
Okay, excellent. Well, that's great news. Okay, can you speak to the incidence of superficial blood clots occurring after a DVT and what treatments are for superficial thrombosis, and how long typically after a DVT they might occur?
Great question. Superficial vein thrombosis implies that there's a clot that forms in one of the surface veins, not the deep veins. People who have had deep vein thrombosis are at increased risk for recurrent thrombosis, and it doesn't always have to be in the deep system. It can also be in one of these surface veins. The primary risk factors for developing superficial vein thrombosis are varicose veins. Patients that have certain malignancies can have an increased risk of these superficial clots, but also patients who've had a prior DVT. Usually what we do is treat these patients not like we would for a DVT. We use a shorter course of anticoagulation, and we oftentimes don't use as high of a dose of anticoagulation, and patients do quite well. One of the regimens we like to use is a drug called fondaparinux, which is an injection, and we do that for about 45 days. It's a once daily injection at a very low dose. Patients do great with that. The important thing is if you see these superficial vein clots forming in someone with varicose veins in the lower extremity, that's actually not only does it suggest that they may need blood thinners, it actually strongly suggests that they may need further testing to see if their surface veins function normally. And if their surface veins do not, then a ablation procedure to close those surface veins actually can help prevent the patient from ever getting another one of those superficial blood clots again. It's actually a class 1 recommendation. A lot of providers aren't aware of that, but it's actually one of the best things you can do for a patient with superficial vein thrombosis.
Oh, interesting. Okay. I have a TAVR. Do I need anticoagulation?
It's a great question. There have been a number of studies looking at that. Usually the TAVR patients have received some form of antiplatelet therapy, either with a combination or single agent, mostly combinations, at least early on. There have been some studies now raising the question of whether we should use anticoagulation in those patients. A lot of those patients have atrial fibrillation due to the aortic stenosis or aortic valve disease and need to be anticoagulation anyways. You could make the case, but also we need more studies to actually change guidelines if that's to be the way we're going to treat patients.
Okay, great. Okay, the new reversal agents for the DOACs. This patient has heard that they have severe cardiac risks and are only to be used as a last resort. Can you talk about their safety?
Yeah, they're quite safe. It'd be interesting to see where that report came from. The reversal agent for dabigatran is called idarosizumab or Praxbind, and the trial that it was studied in, Reverse AD, did not show any concerning signal for heart attacks or other sort of acute cardiovascular events. For the anti-10A agents like apixaban, edoxaban, and rivaroxaban, the andexanet alpha agent also seemed to be safe when it came to cardiovascular outcomes in patients who needed to be reversed. Now, the question is, well, there are two key questions. All patients who are on anticoagulation and suffer a bleed and need to be reversed, by and large, have a very good reason for being on anticoagulation. And if a patient bleeds and has to be reversed, they're going to come off their anticoagulation, and whatever disease they have, whether it's a tendency towards pulmonary embolism or atrial fibrillation, they're going to have an increased risk during that time of forming a clot, and sometimes that clot could lead to a cardiovascular event. But that's largely not something that we can avoid, with the exception of making sure we restart anticoagulation as soon as it's safe. The other possibility to that question is some of the older reversal agents, like prothrombin complex concentrate, or in particular something called Novo-7 or recombinant factor 7A, which were used to reverse warfarin. Those have been associated when you give too much and over-reverse patients or overcompensate. Those have been associated with cardiovascular events, and that's one of the big reasons we don't use recombinant factor 7A anymore.
Oh, interesting. Okay. So this patient has experienced that as her estrogen levels change, that she can almost sense the clots kind of moving through her body. So she went to her doctor about this, and he kind of surmised that there was an interaction between inflammation, estrogen, and her protein S, which she said is not severe enough to warrant going on medication. So she started tracking her estrogen, and she has a lot of monthly spikes. Can you speak to, the kind of connection between estrogen, inflammation, and blood clots, and if there's anything to that theory?
Well, estrogen is associated with an increased risk of blood clotting, either arterial or venous blood clotting. It's one of the reasons we see venous thromboembolism in the setting of pregnancy and postpartum. It's also one of the reasons we saw a lot of cardiovascular events around the use of hormone replacement therapy that contained estrogen. So it's an important very important hormone. It regulates so many critical functions for women, but there is always the risk that it can trigger blood clotting in an adverse way. With regards to being able to feel blood clots traveling, I haven't ever had a patient tell me that, and nothing in my journeys through clinical medicine has, ever suggested that that's something that one might be able to feel unless you're having PEs or DVTs. I've had some patients feel like on anticoagulation they can feel their blood flowing differently, but no one I trust has ever been able to give me an explanation of why that's so.
Interesting. Okay. Have you, and this is a strange side effect from being on one of the DOACs, but a patient ever since starting one has had small white pimples on their face. Is this anything that you've seen in patients on a DOAC?
Sounds like something called mealia, and I've not specifically seen that with anticoagulants, although anticoagulants can cause a number of skin changes or cutaneous findings from rashes to acne. So that certainly doesn't sound particularly strange to me.
Okay, interesting. We have, we've already talked a little bit about orthopedic surgery and best practices in patients with a history of PE. This patient's doctor is recommending that he forego orthopedic surgery because he's on a blood thinner for, the rest of his life. And that his surgeon is saying it's too dangerous for you to undergo the operation. You should really put it off as long as possible until you can no longer live with, the pain from the knee. But it seems that there are safe ways for, surgery to happen. But they're kind of wondering, are the doctor's concerns about him being on a blood thinner for the rest of his life valid in terms of not undergoing the knee surgery?
Yeah, without knowing the specific details of the patient's prior history and the reason they're on anticoagulation, it's difficult to conjecture exactly what the concerns are from the orthopedic surgeon. But I would just say, in general, broad strokes, if a patient needs to have orthopedic surgery and the indication is solid and they're on anticoagulation for a reason, we can usually find a way to safely get them through the surgery and have the surgery done safely with a low risk of bleeding while also protecting them from blood clots. I've never sort of prohibited a patient from going forward with surgery, orthopedic surgery that was, that had a reasonable indication just because they were on anticoagulation.
Okay. So what are your thoughts on this patient has iliac vein compression. They've had DVTs, but they were not located in the iliac vein. One doctor is saying you should have that stented to prevent further clots. Another one is telling her not to. Do you have any advice for this patient?
Sure. First of all, it depends on whether the blood clots were in the same leg as the iliac that's being compressed and whether they actually looked to see if there was iliac DVT or not. A lot of times patients will have a femoral vein DVT in the left leg, which is where you typically see this iliac vein compression that's called May-Thurner syndrome. And they don't look to see if it involves the common femoral vein or the iliac vein. So if they don't look at that, they don't think of May-Thurner. But sometimes all that's needed is to scan a little higher up into the groin, or to use a CT scan to look for blood clot in the veins in the pelvis. And oftentimes, if it's in the same leg and it was above the knee, we will consider performing stenting for a May-Thurner. One of the important things to do when looking at May-Thurner syndrome is to see if there is a pressure gradient across the area of narrowing, because even if there isn't a clot right at that point, if there's a very big difference in pressure, there's a likelihood that clot could form there at some time, and stenting that vein could be very helpful.
Interesting. Okay. Do you know of any interaction or correlation between DOACs and induced insulin secretion?
No.
No. Okay. So, because they're wondering if there's any effects on that they should be concerned about.
I haven't heard of anything. It doesn't mean that such a thing doesn't exist. It's not something that is commonly discussed in the literature.
Okay. All right. All right, this patient uses a foam pillow under her knees for lower back issues at night. And she's wondering if those could have possibly contributed to a PE that she had. She said she's very healthy, very active, and that's the only thing that she can think of.
Only if the pillows put such a strange hyperacute angle on her legs, or put so much pressure that she's actually occluding the veins behind her knee. I've never heard of such a thing, and it would have to be a very specific shaped pillow to be able to cause that amount of pressure behind the knee to narrow the veins significantly. Like I said, I haven't heard of anything like that.
Yeah. Can you talk about aspirin therapy after ending anticoagulants? So this patient has been on a DOAC since 2018. They began to have stomach issues in February, and so they stopped their medication. They're just wondering, they've had a superficial blood clot, if they should start aspirin.
If it's a superficial blood clot, aspirin really hasn't been studied for prevention of those types of blood clots or even treatment. So there wouldn't be any evidence for doing that. And so with that, there's no way I can really say what benefit or harm they might get from using aspirin. If it were a deep blood clot, aspirin's been studied for prevention of deep blood clots that are unprovoked, what we call idiopathic, and it provides some protection, but not as good as anticoagulation. The other problem with aspirin is it does lead to gastrointestinal ulcer disease, and some people just develop GI upset to it. It's not it's not as benign a drug as we thought it was.
Oh, interesting. Okay. If a patient needs to come off her anticoagulant for surgery, how long can people typically be off their anticoagulant before there is a concern?
There's no hard and fast rule for that. In general, we feel like a few days are very safe, and sometimes those few days can become a week or so. The important thing is that providers don't sort of delay or forget about restarting anticoagulation when the patient is recovered from the procedure. If a few days to a week becomes several weeks to months, that's when people start to get into trouble.
Mm-hmm. Okay. Do you know about any natural supplements to prevent or treat blood clots? In particular, they are wondering about nattokinase. And is there a supplement you recommend to help improve vein health?
The issue with a lot of these supplements is they don't undergo the same FDA approval process that pharmaceuticals do. And so when you get them, there's a number of questions. When you buy them, there's a number of questions that remain unanswered. The first question is whether the compound that is reported to be in what you bought actually has any benefit and does not cause harm. And without the FDA doing studies and assessing that, it's hard to know. Another issue is whether what you actually bought contains the compound that you think you're purchasing. So a lot of times people will buy a supplement, like say for example, red rice yeast or saw palmetto or horse chestnut seed extract. Since it's not reviewed by the FDA, you don't actually know that those things are actually in the capsules or pills. There could be anything in there because they're not beholden to FDA approval and FDA oversight. So you don't know that. You also don't know what kind of impurities can be in those capsules. A lot of the manufacturing plants for these nutraceuticals or supplements are overseas, and they don't have the same regulations that the FDA and some of the other organizations place to make sure that the laboratory where they're produced keeps impurities out of the production line, keeps the production line clean. And so, in short, you have no idea what you're actually purchasing. So that's my editorial caution on nutraceuticals, nattokinase or any. The one thing I will say, because the last little part of the question that you snuck in there is whether there was any supplement that actually improved vein health. And there is actually a supplement that's been studied that is more commonly used in Europe than in the US. And it's easier to get in Europe than in the US, that helps in certain types of venous diseases, namely venous insufficiency, and that's horse chestnut seed extract. Horse chestnut seed extract contains a drug that's venoactive, which means it affects vein function, and patients who take that and have a lot of lower extremity edema due to venous insufficiency, either because of prior blood clot or dysfunctional veins, actually have improvement in their symptoms and their swelling. And so that it hasn't been studied as rigorously as some of the drugs we use, but there are actually some reasonably good studies that have looked at it, and it does seem to be helpful.
But again, you should really make sure that you're buying it from a reputable source. And then
if at all, because you just don't know. There's no real oversight from the FDA on the manufacturing of these nutraceuticals.
Yeah. And two, I mean, I know
another, like Catherine, another consideration is look at all the things that have happened with Zantac and valsartan, with the contaminant that is probably a carcinogen. It's probably present in a extremely low dose, but Zantac's been pulled off the market. Valsartan, a lot of people switched off. It's an issue, but nobody's really, who's checking these nutraceuticals to make sure they don't have carcinogenic components? That's the problem. They don't go through the FDA, so you don't actually know that you're taking something safe.
Yeah. And two, I mean, a lot of these, supplements they do interact with medications that you're on, prescription medication.
Absolutely. That's a very good point. Yep.
Yeah. Okay, speaking of medications, if you miss a dose of your anticoagulant, how do you go ahead restarting it? Should you double up on your next dose? Just start taking as normal?
If you miss a dose, what I usually tell my patients is if you're closer to the dose you missed, than your next dose, then you take it. If you're closer to your next dose than the dose you missed, then you just wait for the next dose.
Okay. All right. Could something as simple as a sprained ankle cause thrombosis?
Yes, it could. Inflammation around the venous system can cause blood clots.
Okay. And could it cause a superficial blood clot?
Yes, also. You can directly traumatize the superficial venous system and definitely cause that.
Okay. All right. So this patient has had 2 provoked DVTs and has been on Xarelto for 9 months. They are wondering, so their doctor said you can either stop taking it or you can continue taking it at 20 milligrams indefinitely. And they're wondering if for indefinite, if there's a lower dose, so possibly 10 milligrams.
You can take both. Einstein choice showed that rivaroxaban 10 or 20 functioned well for prevention of blood clots.
Okay.
Especially if and that one included provoked and unprovoked events.
Okay, interesting. All right, good. So I believe that we have answered pretty much every question that has come in, Greg. So that's
Great.
incredible. I know that was a lot of different questions across varying topics thrown at you. So I so appreciate you taking the time to answer them all so thoroughly and thoughtfully.
Oh, I was happy to. I hope that at least some of the attendees found it helpful.
Yeah, I'm sure. So I also want to thank everyone for joining us this evening and for submitting your questions. Like Dr. Piazza said, I do hope that you found this helpful. We are moving to a new model where we are sending out monthly webinars, educational videos for patients called the Patient Pulse. So we do hope that you'll sign up for those because there's a lot of great education there. And then we're doing quarterly Ask the Expert forums. So just like tonight, you can sign up and submit your questions, or if you don't have a question, just log in to hear some general information that we hope you'll find useful. So we do not have the next Ask the Expert schedule, but we are doing it quarterly, so stay tuned and we will send that date out shortly. So thank you so much, everyone. We really appreciate you joining us and have a great evening.